Welcome everyone to our webinar titled ADPKD in Women and Children, Special Considerations. My name is Nicole Torres, Community Education Strategist at the PKD Foundation, and I'll be moderating today's presentation. I'd like to acknowledge OTSCA for their support of this webinar through an independent sponsorship. Please note that the PKD Foundation has full control over speaker selection and content, and this session is intended to provide unbiased, evidence-based education to our community. Kidney Disease Improving Global Outcomes, or KDIGO, is a nonprofit organization that brings together kidney experts from around the world to create comprehensive and trusted guidelines for improving care and health outcomes for individuals living with kidney disease. The new KDIGO 2025 ADPKD guideline provides evidence-based recommendations on diagnosis, slowing disease progression, lifestyle and medical management, and treatment of ADPKD. It helps both nephrologists and patients feel more confident in managing ADPKD by promoting standardized, individualized care and shared decision-making. And without any further ado, I'd love to introduce to you our speakers. We are honored to be joined by Dr. Arlene Chapman, Dr. Ashima Gulati, and Dr. Dallas Reed. Dr. Chapman is a professor of medicine, chief of nephrology, and PKD Center of Excellence clinic director at the University of Chicago. She is a renowned nephrologist specializing in hereditary and rare renal diseases, including ADPKD. She is a leading researcher in cyst formation, mechanisms, and precision medicine, and plays a vital role in academic leadership, mentorship, and translational medicine. Dr. Gulati is a pediatric nephrologist and director of the PKD Center of Excellence Clinic at Children's National Hospital. She specializes in inherited kidney diseases with a focus on PKD. Her clinical and research expertise includes genetic kidney disorders and vascular complications in ADPKD. She is dedicated to improving outcomes for children through early diagnosis, comprehensive care, and genetic research, and is also an active educator and mentor in pediatric nephrology. Dr. Reed is the Chief of Genetics and an assistant professor at Tufts University School of Medicine, a PKD Foundation Center of Excellence, specializing in obstetrics and gynecology, as well as medical genetics. She has expertise in preconception and prenatal genetic counseling, genetic syndromes, and cancer risk assessment, with a focus on women's health and advancing health equity in genetic care. And at this time, I would like to turn things over to Dr. Chapman to get us started on pregnancy and women's health issues in ADPKD. Thank you, Dr. Chapman.
Thank you so much. And thank you everyone for coming at the end of the day. It's a pleasure to be here and to share with you our current guidelines from the KDIGO about pregnancy and women's health issues in ADPKD. So the world of the life cycle for women, girls, and babies have their own risk factors for kidney complications. And independent of ADPKD, I think it's worthwhile remembering that if a baby is born who's small or small for gestational age, they have been endowed with probably fewer nephrons than a comparative, a normal weight baby at the time of birth. Because of this, just birth weight alone has its own higher risk for chronic kidney disease and hypertension during their lifespan. If someone has developed renal insufficiency, menarche may be postponed and menses may be irregular, and particularly with advanced renal dysfunction and with kidney replacement therapy. In women who have advanced renal disease, we know that the ability to conceive is reduced and that pregnancy complications can be more frequent. And as women get older, menopause may occur earlier with an increased risk of osteoporosis in those with chronic kidney disease or receiving renal replacement therapy. It's also sometimes difficult to diagnose menopause in the setting of chronic kidney disease because of irregular menstrual cycles. Now, if there's one slide that gives all the things that KDIGO talks about for women and reproductive issues, it's on this slide. So hormone therapy is a consideration throughout the lifespan for ADPKD women. And so discussion about the risks and benefits of both estrogen and progesterone therapy are important in regard to polycystic liver disease. This includes intrauterine devices and gestogen oral contraceptive pills may be preferred for women with polycystic liver disease. When planning a family, preconception counseling is very important for a number of reasons. One is to make sure that any medications that could be harmful to a fetus or teratogenic are stopped before a woman becomes pregnant. And this includes tolvaptan therapy and inhibitors of the renin-angiotensin system, like ACE inhibitors and angiotensin receptor blockers. It's important for women to know the risks of becoming pregnant, and this includes an increased risk of preeclampsia, pregnancy-induced hypertension, early delivery in ADPKD women. And genetic counseling is very important so that they understand the risk of inheritance of ADPKD with each pregnancy, the potential for fetal and childhood outcomes in affected children, and the potential risk-benefit of pre-implantation genetic testing and egg sperm donation. In addition, when a woman with ADPKD becomes pregnant, management should be multidisciplinary. They should have regular monthly assessment of their blood pressure, their kidney function, and their level of proteinuria by a urine sample by a healthcare provider. It's really encouraged that women check their own blood pressures at home because of the known differences seen between home and office blood pressure and the ability to get more measurements over a shorter period of time. The current suggested target blood pressure during pregnancy for ADPKD women is less than 135/85 millimeters of mercury. It's also recommended that a low dose of aspirin, meaning 81 milligrams, be started at 12 weeks of gestation and stopped at 36 weeks of gestation to help with the risk for preeclampsia. Urine samples should become obtained for monthly screening for urinary tract infections, and if a positive urine culture is found, it should be treated appropriately. And women should be encouraged to increase their fluid intake during the pregnancy, as would be with any pregnant woman. After the pregnancy, there's also some considerations. Tolvaptan and inhibitors of the renin-angiotensin system should not be used while breastfeeding and should not be prescribed during this time. And women with bladder instability or urinary incontinence after pregnancy should be helped to receive pelvic floor physical therapy, especially when there's a plan to use tolvaptan therapy. So with all that said, I'm going to talk a little bit about what happens to the kidney in pregnancy so that people can appreciate that it is a very different situation for the doctors managing pregnant women. And this includes ADPKD women, because the vast majority of ADPKD women, when they become pregnant, have normal kidney function. So what happens during pregnancy? Well, the renal collecting system where urine comes out into the ureter dilates significantly. Blood flow to the kidney increases significantly because there's a big reduction in renal vascular resistance because of the hormones related to pregnancy. So this results in a big increase in blood flow to the kidney and actually a big increase in kidney function or glomerular filtration rate. Because of this hyperfiltration, there's a little bit of proteinuria that can be seen in pregnancy that's normal. There's also a little bit of glucose in the urine because of this increase in kidney function. And women's drive to breathe goes up because of progesterone. So there's a respiratory alkalosis with normal pregnancy. Kidney length will increase by almost a centimeter. And as all of you know, we look at kidney size very seriously in ADPKD. So when we get a kidney volume measurement during pregnancy, we take into account that someone's pregnant and the pregnancy itself is impacting the kidney volume. Renal blood volume will increase by almost 30%, and the collecting system and pelvis will increase in size. Something that happens in pregnancy that's quite unique and is often surprising to some care providers who don't take care of a lot of women in pregnancy or are on the nephrology or renal end of this is that there's a hydroureter or a dilated ureter that occurs normally in pregnancy, which can look like obstruction, but it's not. It happens on the right more than the left. And after delivery of the baby, usually somewhere from 2 days to 6 weeks postpartum, it resolves. And it's probably because there's a change in the peristalsis or the fluid movement through the tubule, and there's a lengthening of the ureters because of the hormones of pregnancy. The other thing that's very important, and this is part of regular management during pregnancy, is the presence of bacteria in the urine. It happens between 2 and 10% of all pregnancies. And if there are more than 100,000 colonies in a clean catch sample, typically this will be E. coli, it should be treated. Diagnosis and prompt treatment is very important. If it's not treated, it's associated with poorer outcomes for the baby, with low birth weight infants, often because of preterm birth. It can also associate with preeclampsia, high blood pressure, and go on to becoming a symptomatic urinary tract infection. So urine gets surveilled quite a bit during pregnancy. There are certain antibiotics that are safe to use, and there are certain antibiotics that should not be used during pregnancy. So those all need to be taken into consideration. So here's an example of what happens to all of our markers in pregnancy. Blood pressure drops somewhere between 10 and 15 millimeters of mercury, all in the first trimester, before there's even implantation of the placenta. That blood pressure stays reduced throughout pregnancy until late in the third trimester and comes back. So monitoring blood pressure, one would expect to see a lowering of blood pressure. This vasodilation triggers the kidney to hold on to salt and water, thinking that it's underperfused, and this results in an increase in plasma volume and a dilution and a reduction in the hemoglobin. So anemia of pregnancy is very, very common. Mirroring the blood pressure, the same thing happens to the renal circulation. So renal blood flow goes up by the 6th week. There is no placenta yet. There's been no implantation. Kidney function also goes up by the 6th week. And this results in a significant reduction in the renal vascular resistance and a change in filtration fraction that changes how the glomerulus works. And there's lots of counter-regulatory hormones that kick in to try and adjust to this vasodilatation that's seen in pregnancy. So this is an example of a large number of individuals in England who had their creatinine levels measured multiple times during their pregnancy. So you can see in the pre-pregnancy phase, there's stable creatinine measurements, and then it goes down almost immediately to its lowest point at the end of the first trimester. And it stays down through the second trimester until the beginning of the third trimester, when it starts to come up around week 35 or 36. There's a slight bump up after delivery, post-delivery, and that then comes back down to where it was before someone became pregnant. So we monitor all these labs during pregnancy, and we worry if we don't see this dip. We track creatinine very closely. We track blood pressure very closely to look for the normal physiological changes in pregnancy. So when we get our labs back for patients when they are pregnant, we see changes. So we see the serum creatinine go down. We see the BUN go down. We see the hemoglobin go down. We see the uric acid go down. We see the CO2 or bicarbonate go down. And we see the serum osmolality go down. And if those don't go down, we start making sure that there isn't something that should be looked at more closely. So the good news is that most women of childbearing potential with ADPKD will have normal kidney function. But one of the things that women need to know about as they plan to become pregnant is that there is a chance that that pregnancy will have a potential negative impact on their kidney function over time. That risk goes up incrementally with reduced kidney function. So if a woman wants to become pregnant and she's at CKD stage 3B or 4, the chances of her losing kidney function because of the pregnancy are much greater than a woman who has normal kidney function or CKD stage 1. And what you see in the graph here at the top are the patients who show a bump up in their creatinine during the pregnancy, and the higher their baseline creatinine before they became pregnant, the more likely they were to lose kidney function during the pregnancy. And there are 4 more studies below that show what happened if a woman with CKD stage 3, now this isn't just PKD, this is all causes of chronic kidney disease, what the chances are that they will lose kidney function during the pregnancy. So in one study in 2021, almost half lost kidney function because of the pregnancy. In the other studies, it was 18%, 17%, and close to 40%. So something to talk about with your doctor. So what happens with women who become pregnant with chronic kidney disease? First of all, a successful pregnancy is possible across all severities of chronic kidney disease, and it's also possible with a kidney transplant. Women with chronic kidney disease have an increased risk of high blood pressure and delivering the baby early. And the risk is increased in CKD G1 and increases with increased progressive impairment of kidney function. So if someone comes in with CKD stage 3 or 4, chances are that their baby will be delivered earlier than a woman who comes in with CKD stage 1. There are some complications that are more common in women with chronic kidney disease. They're often related to the growth of the baby. It can be intrauterine growth retardation, small for gestational age. It can be early delivery. It can be a C-section. And so it's important, particularly for those women with advanced kidney disease, that they're aware of this and they have the team with them as they plan to move forward with their pregnancy. There's also an issue of reduced fertility in women with advanced CKD, and I'll come back to that in just a minute. And there are limited data available to know what the efficacy and safety of in vitro fertilization with chronic kidney disease is, and that deserves a discussion as well with your doctor. So timing in pregnancy and chronic kidney disease is critical. It's important whenever possible to have blood pressure well controlled, the level of proteinuria optimized, making sure that all the treatments are in place, and in individuals who've had a transplant, that the appropriate immunosuppressive therapy is being given. And defining an individualized best time for pregnancy after a transplant deserves to be discussed as well. So here are some of the medications that are available for a variety of different treatments, and it gives you an idea of the medications that are considered safe, considered for caution, and where they just haven't been studied enough. So when you look at the medications for treatment, there are a number that are shown here that have been tested in women with chronic kidney disease before they become pregnant. And I want to point out here that there is really no real role for the ACE inhibitors that are listed here. I don't know how this ended up on the slide, but I think these were used for patients when there was a trend towards needing extra help. So please ignore the captopril and enalapril that are listed as being safe for the treatment of hypertension. Iron is been shown to be safe for anemia. Bone mineral salts such as calcium salts and calcitriol have been shown to be safe. There have been immunosuppressant medications that have also been tested in certain cases of pregnancy. And this is a variety of medications that should be reviewed to make sure that you are safe with the medications that you're taking before you become pregnant. So, what are the current guidelines for blood pressure control during the pregnancy? And when I first showed you the KDIGO guidelines, we used what was the American OBGYN recommendation for pregnancy blood pressure goals. And we also used the guidelines from the United Kingdom as well. But you can see there's a range of blood pressure goals depending on the country where you are living and where you're getting your treatment. So in Italy, in chronic kidney disease and kidney transplant, the ideal target is less than 130/80. Sometimes patients will creep up to 140/90, but these require careful clinical surveillance with the patients with good compliance. In the United Kingdom, it's 135/85 or less. In Germany, it's a range between 110/70 and 135. And in the Netherlands, it's less than 130/80. So you can see they are a little different depending on the country that you live in, but they're relatively similar to each other. And so what are the recommendations for monitoring based on the level of kidney function during pregnancy? For patients with CKD1 or CKD2, every 4 to 6 weeks, with monitoring for blood pressure, and if changes in blood pressure occur, or proteinuria, perhaps more frequently. In those with CKD stage 3 or 4, more frequent monitoring is recommended. And then the types of tests for CKD1 and 2 patients are generally kidney function with a creatinine or cystatin C, proteinuria, electrolytes, iron status, CBCs, urinary cultures, and sometimes patients will undergo 24-hour urine collections. For CKD stage 3 and 4, this is similar to CKD stages 1 and 2, but with monthly or more frequent monitoring, oftentimes with a 24-hour urine. So preeclampsia is a condition that occurs only in pregnancy. It is a risk factor for women with ADPKD with normal kidney function. It's defined as having new onset or worsening high blood pressure with an increase in urinary protein or the development of proteinuria and edema after 20 weeks of gestation. And what we see in the kidney when this occurs is a swelling and decreased blood flow to the glomeruli, which are the functioning units of the kidney. And there's a lot of pathological changes that occur when this happens. And preeclampsia, the only cure for this is to deliver the baby. So we try our best to get women and their babies to a week of development and timing as close as possible to a full pregnancy or term delivery before delivery. But sometimes, for protection of both mother and baby, the baby has to be delivered early. So what happens here is with chronic kidney disease or ADPKD, a woman could become pregnant. And when we see an increase in proteinuria, if we see a decrease in kidney function or an increase in serum creatinine, we worry that there is the development of preeclampsia, which is really a problem with the cells that line the vasculature. And this is called the endothelium. And this is really because the placenta is struggling and releasing a number of cytotoxic compounds that attack the endothelium in the kidney, often in the liver, often in the pancreas, often in the brain. So it's a systemic disease, but it's marked clinically by an increase in proteinuria and a loss of kidney function. So what happens when preeclampsia develops is that there's a decline in kidney function and there's a decline in blood flow. So all that vasodilation that happened in pregnancy is reversed. And the decrease in renal perfusion leads to a decline in vascular volume, an increase in vasoconstriction, and there's some inflammatory markers and coagulation changes that occur because of the injury to the endothelium. And this can also lead to abruption of the placenta and hemorrhage. So it's a very serious condition, and that's why everyone is very aware that it can happen and monitor women very, very closely during their pregnancy to check for the development of this potential complication. The way their patients are handled is they're given supportive treatment, there increases in intravascular volume, they're given magnesium to help reduce the risk of central nervous system effects. And again, delivery of the fetus in the placenta is what cures the disorder. So this is an example of what happens and why it happens. And you can see the dotted lines here, and it shows how well the placenta can actually build in to the wall of the uterus during a pregnancy. And in the normal pregnancy, there's lots of branching angiogenesis, so lots of vascularization of the placenta. And you can see in women who become preeclamptic, that nice invagination into the placenta is delayed. So the dotted line moves over to the right later than it should. And it also doesn't go in as much. So it's really placental insufficiency. The placentas don't have enough vasculature to allow the babies to develop fully over a full term. And if we think about thresholds for why this happens and look at the blue lines here for women without kidney disease, no chronic kidney disease, no ADPKD, you can see that their endothelium is doing quite well before they're becoming pregnant. Women with ADPKD, women with chronic kidney disease, endothelial function before becoming pregnant is not entirely normal. It doesn't manifest itself as a clinically treatable situation, although high blood pressure is in large part because of the endothelium, but they start the pregnancy at a higher level. And then if there's a problem with the placenta maturing and growing and building its vascular beds, then there's an even higher chance of endothelial dysfunction. And that's what results in the preeclampsia that we are so carefully monitoring for. So what about kidney transplant? So when women get a transplant, all of their renal dysfunction reverses and they regain endocrine and sexual function very close to women without kidney disease. And the ability for a woman to become pregnant increases significantly to 1 in 50 individuals. Approximately a third of women with a kidney transplant who become pregnant don't successfully progress beyond the first trimester, but those who reach beyond week 12 invariably succeed with delivery of their baby. There are a number of things that can happen to a woman with a kidney transplant, not unlike chronic kidney disease and not unlike ADPKD. They can develop high blood pressure. They can deliver the baby early. The baby can have intrauterine growth retardation. The women with a transplant who tend to do better are those who have good kidney function in their allograft, those who are stable with a low dose of steroids before they conceive. The longer it's been since they've had the transplant, and most doctors recommend that women wait 2 years before trying to conceive, and if they don't have proteinuria before they become pregnant. And this is an example of what happens to 24-hour urine protein excretion in normal patients that are shown in the shadow area and those with transplant. So there's a slight increase in the level of proteinuria in most women who undergo pregnancy who've had a kidney transplant. So this is, again, coming back to all of the different phases that women need extra care, usually from a multidisciplinary team that includes an obstetrician who knows how to take care of women with chronic kidney disease, and a nephrologist and a primary care doctor. So there should be individualized preconception counseling, optimal blood pressure and albumin creatinine ratios, conception and pregnancy safe medications, and thinking about prior pregnancies and what impact that had on a patient before they became pregnant. Early booking for an appointment is important. Multidisciplinary care is important. Aspirin from week 12, pregnancy safe medications, monitoring closely for preeclampsia, targeting term delivery if we can do it, and induction and cesarean for usual obstetrical indications. Postpartum, midwifery care and follow-up, encouragement and support for breastfeeding, medication reviews, and monitoring for disease progression. And intrapartum, before delivery, targeting spontaneous vaginal delivery whenever possible, midwife with maternal medicine knowledge, fluid monitoring, kidney function monitoring, and management for peripartum bleeding should it occur. So what about dialysis? Dialysis is a different situation. The risks are much greater to women. First of all, it's much less likely they'll become pregnant. The chances of a baby making it to a live birth is reduced. The better outcomes that occur for women who are on dialysis are those who've dialyzed for a shorter period of time and those who have some residual kidney function. And maternal and fetal complications are high. The reason that women don't become pregnant is that many of their hormonal levels are higher than they should be because there's no kidney to excrete the hormones. So there are too much GnRH, there's too much LH, and there's not enough estrogen, progesterone, or testosterone. So fertility goes down for both men and women who are on dialysis. So luteinizing hormone that comes from the brain is too high. It doesn't allow for ovulatory surges, and there are elevated prolactin levels. So women typically don't ovulate with late stage kidney disease or on dialysis. And when you look at whether or not women have menstrual cycles, regular menses, it's much reduced. And they also are at higher risk for bleeding heavier with menorrhagia on dialysis. So this is an old study, but it hasn't changed too much. And it was of 318 women on dialysis, and over 85% delivered the baby early. Close to 30%, the babies were very low birth weight, and 11% had congenital abnormalities. And if you look at the biggest cause of loss, it's really not different in the first trimester compared to non-ESRD patients. But what is very unusual is that there's a number of second trimester losses. And this is really related to the biochemical makeup of a mom when she's on dialysis. So the higher the BUN, the more likely a woman is to have an early, go into labor early in the second trimester and lose the baby. So our dialysis patients, should they become pregnant, we try to dialyze them 6 days a week. So polycystic liver disease is more common in women with ADPKD. It's more severe in women with ADPKD, and severe involvement can require treatment, is more common in women. It's thought to be related to exposure to hormones, particularly estrogen. It's been associated with pregnancy. It's been associated with hormone replacement therapy, both, and also for birth control. So when we look at liver growth rates for women less than 48 years of age who are still making estrogen in their ovaries, the liver grows at approximately 2.65% per year. This slows down dramatically following menopause, and the growth rate is barely detectable once estrogen leaves the system. So this is thought to be the effect of estrogen in pre versus postmenopausal women. And the significance of use of estrogen-containing birth control, hormone replacement therapy, and other high estrogen states deserve to be talked with women who have polycystic liver disease. So any chance to avoid unnecessary estrogen is a good thing. Estrogen-containing birth control, when there are non-estrogen forms that are equally effective, might be discussed. Pregnancy doesn't get discouraged, but I think knowing what this can do to the liver deserves to be shared with a woman when she's planning to become pregnant. In high-risk women who have severe polycystic liver disease, re-imaging the liver can be very helpful to help guide decisions in terms of care and continuing of estrogen replacement therapy. So with that, I'm going to say thank you, and I'm going to pass the baton on. Thank you so much.
Good evening, everyone. I hope everybody can hear me fine. It's a pleasure to be here today. I'm a pediatric nephrologist with deep interest in managing children with PKD. And tonight I'll be sharing some insights on navigating the KDIGO guidelines for ADPKD, and more specifically, how these recommendations relate to children who have ADPKD or are at risk for developing it. So Chapter 9 of the KDIGO guidelines, I have nothing to disclose relevant to this talk. Chapter 9 for the KDIGO guidelines discusses the pediatric issues with ADPKD, and we'll touch about some aspects, but mainly focus on the diagnosis of ADPKD in children, when and how to screen ADPKD in kids, what the guidelines have to say about managing blood pressure and other symptoms in children with ADPKD, and also touch upon the importance of genetic counseling. For the diagnosis of ADPKD in children, I would like to say that diagnosis of polycystic kidney disease in children is really an age-based spectrum, and there is overlap of two distinct forms of PKD in children. Pediatric PKD presents primarily in two forms, the autosomal recessive and the autosomal dominant. The autosomal dominant form is the one which is more common, and that's the form that we are talking about today. ARPKD deserves a mention here because in the early age group, in the perinatal to infancy and early childhood, there might be some kind of a diagnostic overlap that's possible between ADPKD, severe presenting early ADPKD, and ARPKD. And so being aware of that diagnostic overlap allows us to ensure accurate distinction between these conditions, especially relevant in the perinatal to infancy period. More so, ADPKD can sometimes overlap with other syndromic cystic kidney conditions that can occur in infants and children. In addition to ADPKD, there are many others, single gene causes which are mainly the ciliopathy genes that can show cysts in the kidney and can have a similar presentation like ADPKD. Because most of these conditions that cause cysts in the kidney can be phenotypically variable, and there can be considerable overlap in how the clinical presentation is, because most of these proteins are widely expressed, and the predominant organs that are involved in these conditions are primarily the kidneys and the liver. And so KDIGO just places a big emphasis on the diagnostic accuracy of ADPKD for this reason, especially in children. Looking at this table, in which the diagnosis of ADPKD in children has been divided as basically in two major forms. One is the symptomatic or severe polycystic kidney disease, severe ADPKD in children, which can be very early or early onset. Very early onset would be something that comes to clinical attention even before 18 months of age. And then early onset ADPKD that comes to clinical attention because of either massive kidneys or high blood pressure or poor GFR before 15 years of age. And then there is a form which is the more common form, and that is the ADPKD that is clinically asymptomatic. KDIGO places an emphasis on accurate diagnosis of early presenting ADPKD because it has management implications. Recognizing this early presenting, less common, but more severe form of ADPKD is very important, because there will be distinct management implications on the in the early presenting ADPKD. Especially genetic testing can be extremely useful in early presenting ADPKD, which is atypically severe, and especially when it's in the absence of family history, because it's possible that there are contributions from other genes, and it can be more genetically complex than the childhood ADPKD that comes to attention much later on. So very early onset and early onset ADPKD are these rare and distinct sub-entities, and they can have an impact on the level of the maternal and fetal medicine care that's needed. So it can be very informative to families as to what preparation is needed for that pregnancy and for that delivery. One important point to note is that low amniotic fluid during pregnancy in ADPKD in an ADPKD affected or a fetus that is potentially affected by ADPKD does not necessarily predict a severe prognosis. This is different than some other conditions where presence of low amniotic fluid would entail a poor prognosis or could define a severe short-term outcome, whereas in ADPKD, that data is lacking, and we don't know if low amniotic fluid during pregnancy in an ADPKD-affected fetus is going to translate necessarily into a severe prognosis. So that information is very important for families and providers. The other more common form of childhood ADPKD that we encounter more commonly in the clinic is the typical asymptomatic form. So children may be diagnosed with ADPKD either incidentally, just because they got imaging for another unrelated reason, or it could be an imaging that was done because of the presence of a family history. And so this is the more typical asymptomatic form that comes to clinical attention just because it was screened for. So what about diagnosing these asymptomatic ADPKD in children who are at risk because of family history? When should we screen and how to screen for ADPKD in kids? This is an area that has been an ongoing debate in the field. And the guidelines have tried to address and provide practical guidance to navigate this question. But traditionally, there's been a lack of clear guidance to the pediatrician, who is always the first point of contact. Even though pediatric nephrologists may have more knowledge and may be better equipped to handle those conversations, the pediatrician is mostly the first point of contact for these families, and there isn't a clear guidance to the pediatrician as to what to offer in terms of screening and when to screen. The main reason for this gap in the field has been the lack of any validated stratification models to identify children who are at risk for getting severe disease. Who are the kids who are at higher risk for kidney disease progression? And more importantly, because there are no approved therapies for children, so it's always been a dilemma in the field whether to screen or not. When there is a decision to screen, there are two major modalities. One, the first modality is the imaging modality, and the ultrasound is the imaging of choice because it is easily available, less burdensome, less costly, also to less discomfort to the child. And ultrasound is often the first kind of imaging that's done for these children to screen for kidney cysts. Ultrasound has its limitations. Even a negative ultrasound in a child who is at risk because of a family history would not be definitive in ruling out ADPKD that could develop later. Definitive ruling in or ruling out of the diagnosis would require genetic testing. But genetic testing can only be definitive if the familial variant is definitely known. In families where the familial variant is not known, genetic testing may or may not be definitive and can become inconclusive. And above all, genetic testing in children has numerous legal, social, and ethical implications. So both of those two modalities to diagnose ADPKD in at-risk children have their own limitations. So what does KDIGO what do KDIGO guidelines offer as a practical direction? The guidelines suggest discussing the benefits and harms of screening or not screening and using a mainly family-centered shared decision-making approach in which there is information that a provider should be providing to the parent or the family, and that information should include a discussion of the benefits of screening and the harms of screening. And I'll go to a table in a second that offers practical guidance for that discussion. But then also it places a lot of responsibility on the families to ultimately decide what their personal preference would be after hearing that information. And once they have discussed options of ultrasound imaging and genetic testing with the provider. This is a table that talks about, on the left side, the value of early screening, and on the right side, the complications of early screening. It's not a table that is specifically tailored to the diagnosis of ADPKD in children, but it talks about factors about when to consider the testing for people at risk for ADPKD. So of note, the value of early screening is to enable an accurate diagnosis, to enable people to be enrolled in clinical trials. It can offer reassurance. It can also be informative in appropriate family planning and to facilitate testing of other family members. And then more importantly, it can open avenues for good lifestyle interventions early on. There are complications in terms of having a psychological burden of a life-altering diagnosis. And then, as we discussed, imaging and or genetic testing may be inconclusive. So as you can well imagine, this is a discussion, a model that needs to happen between the providers and the parent. There is also a mention of involving the mature child in this discussion. There isn't a clarity of what the meaning of a mature child would be, but in general terms, in pediatrics, the mature child usually relates to the legal age of assent, and in a developmentally appropriate 7-year-old would be usually the age for legal assent. So involving the family, involving the mature child when possible, would be the structured framework of providing this information and then having a shared decision-making approach. What is needed is a clear guidance still for the pediatrician, because the guidelines do mention that the pediatrician with ADPKD expertise should be the one explaining all this and is often the first point of contact. But I think the field really needs a focus on pediatrician education for pediatricians to feel well equipped to handle those discussions. Next, we come to management of blood pressure. We know that there is robust adult data and there is some pediatric data about the use of intensified or very strict blood pressure control and how that can favorably affect cyst progression and PKD progression and slow down the decline of the GFR. And to that effect, the guidelines do mention strict, very intensified blood pressure control is recommended for children with and adolescents with ADPKD. The guidelines recommend targeting blood pressure to less than 50th percentile for the age, sex, and height of the child. And typically in pediatrics, when we go by centiles, we usually target blood pressures below the 75th centile or below the 90th centile. Going below 50th centile is really means offering the child with more than one medications, or even runs the side effects of getting lightheaded or getting dizzy with lower blood pressure. But because of this, because of the data from adults and limited data in pediatrics of of slowing down the risk of kidney progression, this intensified blood pressure control has been made as a recommendation. But as we realize, there are implementation challenges with lowering the blood pressure to this level in children. And so a more practical approach in the clinic is often to target blood pressure below the 75th centile, which is still higher than the 50th centile, but still targeting a normal blood pressure. And there is some data to suggest that targeting less than 75th centile has good effects on long-term cardiovascular outcomes. And the European Society of Hypertension actually has a target recommendation of less than 75th centile. And usually pediatric nephrologists in the clinic adhere to these recommendations rather than trying to give more than one medication and trying to push the blood pressure below 50th centile. One of the practical challenges in the clinic is that the blood pressure charts that we as pediatricians use has the 50th centile and the 90th centile, but there isn't a blood pressure value of for the 75th centile listed on those American Academy of Pediatric blood pressure charts. And so it's often just calculating midway between those centiles to come to what number you would be targeting. So it's a practical challenge in the clinic. Most importantly, the follow-up of children with ADPKD, in all children with ADPKD, the guidelines also suggest testing blood pressure and urine protein for all children at risk, irrespective of the diagnosis, whether a family chooses to get for the child to get diagnosed or not. Testing blood pressure and urine protein as actionable CKD progression delay opportunities, and to utilize these parameters is really key and should be done in all children at risk, irrespective of diagnosis. In terms of other symptoms, usually pediatric ADPKD, as we said, is asymptomatic. And if there is a severe onset with high blood pressure, that can be managed, and there can be targeted medications for that. In terms of other complications, extra or non-kidney complications are more prevalent in adult ADPKD, and in children with ADPKD, usually there isn't a need to routinely monitor for extrarenal complications, and that's what the guidelines also advocate for. So liver involvement is not something that we routinely see in children, so liver imaging may not be needed in all children with ADPKD. I wanted to mention specifically the vascular or the intracranial aneurysm screening, which is recommended in adults with family history, especially of intracranial aneurysms. In children, this complication is almost non-existent. And so to avoid unnecessary anxiety, we as pediatric nephrologists would not typically discuss this in detail. But also, I think it is important to use that opportunity to counsel families, because when you see the child with ADPKD in the clinic, you also see the entire family, and that's an opportunity to discuss that kind of a less common but devastating complication with the family, and to importantly revisit that discussion around the transition of care when the child turns 18 years of age and would be maybe a candidate for intracranial aneurysm screening depending on the family history. There is a description of transition of care models in the guidelines. There is emphasis on seamless transition of kids to adult nephrology PKD care, and this is a time which is tricky because kids are often leaving for college. So having that transition of care model developed and facilitated is really important for any pediatric PKD clinic. I do want to take a minute talking about the importance of genetic counseling, mainly in the context of prenatal consults that we see in pediatric nephrology. And I will skip this part because Dr. Reed will be talking about this, but preconception genetic counseling has been emphasized. In terms of as we are offering more and more genetic testing for children with ADPKD who are at risk, genetic counseling really becomes very important. And I think this is something that is being emphasized by the guidelines. And this is something that the patients and the families should be aware to seek that kind of genetic counseling, which can really be very important and informative and can guide them through choices and selections. Again, Dr. Reed will be talking about the maternal fetal medicine care capacity building, so I will skip this. But I do want to take just for as the last slide, I want to mention that the guidelines do offer very practical guidelines about or directions or practice points of how to talk when we see prenatal consults or when there is a pregnancy with a potential fetus affected with ADPKD. More importantly, during pregnancy, if the fetus is at risk because one of the parents has ADPKD, a normal fetal ultrasound definitely does not rule out ADPKD. And equally important, it is to note that even if you have mild or severe radiographic abnormalities in the fetus who potentially has ADPKD, it does not necessarily equate to predict a severe ADPKD in the child. It could mean that we are picking up some mild radiographic abnormalities because we have better screening tools and we are more proactive in screening. And in severely affected fetal cases, there is lack of systematic data to definitely say that it suggests a poor outcome. So that kind of counseling is very ADPKD specific and different from some other polycystic kidney diseases and other cystic kidney diseases that we see in pediatrics. So there is a very practical recommendation for prenatal consults. So I would, like to end by saying that these guidelines are great, and but guidelines have a very careful selection of words, and they can be very, what those guidelines are saying can be very different depending on the applicability to the patient who's being treated. So it's up to the treating physician to assess the candidacy of the patient and to see what part of the guideline is applicable to what patient. But they do provide a very good and valuable framework for managing these discussions, especially in the pediatric kidney clinic. But we really need to focus on pediatrician education, on ADPKD screening in pediatrics, and also on multidisciplinary capacity building. So we have a genetic counselor, a pediatric nephrologist, well-informed pediatrician, so that we can execute these knowledge-based PKD recommendations. And with this, I will end here and invite Dr. Reed.
Thank you. Thank you all for staying on. I know there was so much important stuff to talk about, so we're kind of getting to the end of our time. I'll turn my light on here a little bit. But like we said in the introduction, I'm an associate professor of medicine, OBGYN, and pediatrics at Tufts. And I, in my clinical practice, see individuals with PKD who are considering pregnancy and considering genetic testing. So that's what we'll focus on today. And I realize that the talk is really around the female partner. That's kind of how we focused it. But I think it's important to think about in the setting of, especially couples that are interested in vitro fertilization or fertility treatments, that a male partner with PKD may also have some concerns that could affect that process of in vitro fertilization. And so there's just one slide on the male reproductive considerations. And we know in men with PKD, there can be sperm abnormalities due to motility issues in the cilia. The cilia are like little hair-like projections that are in the vas deferens, which is the tube that goes from sort of the prostate, or from the, testicles, out up to the seminal vesicles behind the bladder. And so if those cilia are not working properly, it doesn't move the sperm along. And so that can cause issues with necrospermia or, abnormal sperm. There can also be dilations of the seminal vesicle, which is circled here in this picture. The seminal vesicle creates important substances to sort of help the viability of sperm and the like ejaculation that occurs. And so dilated or cystic seminal vesicles can cause issues with fertility, and then ejaculatory duct cysts may also occur. So that may cause issues as well. So it's important for the male partner to be evaluated as well if you're considering fertility and having children. But for the female partner, we know that there could be, especially if there's normal renal function, as Dr. Chapman alluded to, there is probably not issues with becoming pregnant if those hormone levels are normal. There potentially is an increased risk of ectopic pregnancy. Ectopic pregnancy is a pregnancy outside of the uterus. The most common location of an ectopic pregnancy is in the fallopian tubes. The fallopian tubes also have those cilia-like projections that can move the egg from the ovary through the fallopian tube into the uterus. And so for people with PKD, there may be an impact on that cilia that gets that unfertilized egg trapped in the tube, and then the sperm comes and fertilizes the egg, and it sort of stays there. Ectopic pregnancies are not viable pregnancies. The fallopian tube or the area outside of the uterus isn't really equipped to carry a pregnancy to term. And ectopic pregnancies can be life-threatening because they can cause life-threatening bleeding. So it's one of the gynecologic emergencies that we see. If patients are bleeding or having an ectopic pregnancy, we have to treat that appropriately, and it's not viable. We've talked already about some of these points here, that a patient who has PKD should be obviously following closely with nephrology. We recommend, especially if their diagnosis is well controlled, at least an ultrasound within a year prior to conception to assess cyst size. And as we've already discussed, the known medication is a class D medication, which means it's not recommended in pregnancy. In some of the guidelines, obviously we've talked a lot about blood pressure control and how that's very important in pregnancy. And so patients who already have baseline proteinuria There is some guidance to potentially continue the ACE inhibitor or ARB until the positive pregnancy test. These medications can affect the renal function of the fetus, although the renal function isn't affected immediately once becoming pregnant. And so once a positive pregnancy test is obtained, then stopping those medications should be recommended and switching over to other safer medications for pregnancy. If there is no proteinuria prior to pregnancy, then stopping those medications prior is recommended. Always kind of weighing the risks and benefits. We've talked a little bit about this already as well. It's obviously very important to have a multidisciplinary team for people who have PKD to make sure that they are being watched very closely and their health is optimized prior to pregnancy. And so a conversation with a maternal fetal medicine specialist or a high-risk obstetrician is typically recommended in the preconception period. So, this requires being thoughtful about becoming pregnant, but having a conversation about what specifically would need to happen, when tests would be performed, how they would monitor that particular pregnancy. Some of those decisions are going to be individualized to the situation that the person is in. Also, those conversations about when would be signs of needing to deliver the baby earlier if that's necessary, or how would the growth of the fetus and the blood pressures be monitored. I'd also suggest, which isn't taken up enough in the United States at least, but preconception obstetrics consultation or a preconception visit where you talk to an OBGYN just about other ways to optimize your health prior to becoming pregnancy, and also thinking about genetic testing that's not necessarily focused on the PKD, but just about other genetic conditions that we know people can be carriers for. This could be something that you may not even know runs in your family because nobody has a condition, but your fetus could be at risk of having conditions detected on carrier screening. So we would recommend all of the usual things that people should do prior to becoming pregnant to be prepared as possible. We've touched on this already, but the usual lifestyle modifications, a healthy weight, exercising, decreasing caffeine intake, avoiding smoking and drinking alcohol, of course, are always recommendations we would give any person prior to pregnancy, and obviously during pregnancy as well. So I'll focus a little bit more on the genetic counseling and genetic testing part. So for individuals who are interested in either doing in vitro fertilization or wanting to know, if they want to test a fetus or a newborn or a child for PKD, you first have to have a genetic test that shows what the mutation is in the family. And so you cannot do like IVF if you do not know what the genetic change is. And we know that there's a proportion of people with PKD who definitely have the condition, but there is not a known genetic cause. And so really the first step, if you think you're going to want to use that information for family planning, is to meet with a genetic counselor or a geneticist like myself to talk through the family history and talk through the genetic testing options. In a genetic counseling appointment, there's usually this pre-test counseling where the genetic counselor or geneticist obtains a family history and understands your personal history. We draw something like this, which is called a pedigree, which is just basically a family tree, but is focused specifically on medical conditions that might be going on in the family. In that visit, there's also a discussion about what is PKD, although you likely may be very familiar with that. What is the genetic testing options? What are the pros and cons or risks and benefits of genetic testing? What types of results can come back? What some people don't know is that genetic testing isn't always a positive or negative. Sometimes there's this middle result, which is called a variant of uncertain significance. That really requires, especially in somebody who we know has PKD based on their ultrasound findings or other findings, it really takes a skilled person to be able to evaluate those uncertain findings and determine if they think that they may be causing their PKD. And so a genetics person is usually the person that needs to be doing that evaluation. We also talk about insurance coverage for the actual genetic testing, but also what the laws are around genetic testing in relation to insurance, like life insurance and disability insurance, et cetera. The genetic counseling team or genetics team would offer the testing to you if somebody was interested in pursuing that. They would order the testing, collect the sample, send it off for you, and then when the results come back, there's typically a post-test counseling, either appointment or conversation, to disclose those results, help with coordination of care with specialists if those were not already in place. And one of the very important things is what we call cascade testing, which is testing of other family members. This is specifically adult family members, but the discussion about testing children, when should we test children, if we should test children, would also happen in that type of appointment. So for individuals who are interested in pursuing in vitro fertilization to conceive, this is a process in which the female ovaries are stimulated with medication. I should say this type of process would be done by a reproductive endocrinologist and infertility specialist, or REI specialist. They would give, after doing their full evaluation and making sure that otherwise the couple is healthy, they would stimulate the ovaries with medication, usually injectable medication, and have the ovaries make lots and lots of mature eggs. And then a procedure under anesthesia would occur that's called an egg retrieval, where the patient is put to sleep or sedated, and then there's a needle that goes in, usually through the vagina and cervix, to obtain all of the eggs that are there. Typically at that point, the sperm are also prepared. The sperm is usually provided at the same time. And then the sperm and the egg are mixed together, and that creates embryos. And then after several days of growth, embryos are eventually transferred in to the uterus through a procedure in the office. And then hopefully that is successful and a pregnancy is obtained. So there is the ability, once those embryos are formed, to do some genetic testing on the embryos in order to see if they have the familial genetic mutation that's there. And so that process is called pre-implantation genetic testing, or PGT. And in that process, that fertilization occurs. So the sperm here and the egg are mixed together. After it grows for several days, the embryo is essentially a collection of like hundreds of cells, and they'll biopsy a few of those cells, freeze the embryo, and send those cells off to a specialty laboratory. There's only a couple in the country that do genetic testing of embryos. And then from there, they determine which embryos have the genetic mutation and which embryos do not. And they kind of mark all of them and label all of them appropriately. It's then up to the couple to decide which embryos do they want to use going forward to create the pregnancy. Understanding that PKD is a dominant condition, meaning that if an individual has PKD, there's a 50% chance each of their children will have the condition. And so many couples, although they may have many embryos and test them, it might be that more of the viable embryos have the PKD genetic mutation. And so there are some couples that may still transfer a PKD embryo because that may be the only viable embryos that they have available. But at least they're aware of that risk and can plan accordingly. So the pros of doing in vitro fertilization with PGT is that you can prevent passing on a genetic mutation to a child. So this is for lots of genetic conditions, not just PKD. It also sort of freezes time. So we know that as female patients get older, there is an increased risk of genetic conditions like Down syndrome, for example, or other genetic abnormalities. And so a benefit of doing this is that once you freeze those embryos, they're sort of stuck in time at that age, and they don't have an increased risk of those other genetic conditions over what they would be at the age that the female partner was at the time of the IVF treatment. You also can do other screening for embryos. So on the previous slide, I had some other acronyms. There's one that's called PGTA, which is for aneuploidy. Aneuploidy is things like Down syndrome, for example. PGTM is for monogenic conditions. PKD is considered a monogenic condition. And then there are individuals that have what we call structural rearrangements, which is where chromosomes are sort of stuck to another part that they typically aren't stuck to. And so there may be the opportunity to do screening of embryos for things like that. Again, you have to know, not the aneuploidy screening, but for monogenic and structural rearrangements, you do need to know what you're targeting. So you need to have already diagnosed the parent with something in order to look at that. As good as this sounds for some people, IVF is very expensive. Oftentimes, even if the IVF portion is covered by insurance, the actual genetic testing of the embryos is not, even if there is a known genetic condition in the family. And so IVF can cost, tens of thousands of dollars. There may need to be, the process may need to be repeated. So if there aren't enough embryos that make it to the biopsy stage, or if all of them have PKD and that's not acceptable to the couple, you may need to go through the process again of retrieving embryos, retrieving eggs, and fertilizing them. And so all of this takes actually, many months, as you can imagine. You may still have embryos that have the genetic mutation. The other thing is that embryo biopsy, although it's, if they see a mutation in the cells that are present, that's very accurate. But if they don't see that mutation, it's not 100% sure that the embryo does not have the mutation, because again, you're only taking a few cells from this organism that's thousands of or hundreds of cells, and you could be biopsying part of what's going to be the placenta eventually, and not what's going to be part of the embryo eventually. So that we always make a recommendation to do genetic testing in the pregnancy as well to confirm, although I will say many patients do not take us up on that offer, and they just feel reassured that the embryo biopsies were negative. And then obviously, we've already talked about the risks of pregnancy with PKD, but there are also risks of pregnancy with IDS, including the risk of multiples, the risk of congenital heart defects. There can be some risk of some other genetic conditions that can happen from the IVF process that we don't fully understand, but we know those risks are present. Prenatal diagnosis I alluded to just a second ago, which is doing genetic testing in a pregnancy. It allows for couples to know if the fetus does or does not have the genetic condition. This again goes for other genetic conditions, not just PKD. It can also help couples decide where to deliver if they know that the fetus does have the condition, and have prenatal consultations with specialists like Dr. Gulati, for example, if they know that the fetus does have the condition. The two prenatal genetic tests that can be offered are CVS, or chorionic villus sampling, which involves either a catheter that goes into the vagina through the cervix and gets a small piece of the placenta, or sometimes that a needle comes into the abdomen to get a piece of the placenta. It just kind of depends on the location of the placenta. This is done using ultrasound guidance. So here's the ultrasound here. And this little piece of, section of placenta gets sent off to a laboratory where you can do the genetic testing to screen for PKD in that pregnancy. The downside of doing this procedure is that the risk of miscarriage is probably about 1 in 500, although that risk is obviously much lower than the risk of having a fetus with PKD, which would be 50%. 1 in 500 is about 0.05%. CVS is limited in some regions of the country just because it takes specialized training, and so it's not always available everywhere. But you can also do other genetic testing, like genetic testing for Down syndrome, for example, with a CVS. Amniocentesis is pretty similar, except it always is a needle that goes through the abdomen, and you're getting fluid from around the fetus. It's done later in pregnancy, also usually 15 weeks or 16 weeks and on. And it also is just another way to obtain DNA, and you can do the same type of testing with an amnio sample. The risk of miscarriage is also similar, about 1 in 500 risk. And then it's important to recommend or to discuss that there's other options. If somebody has PKD and they're trying to figure out how to build their family, certainly having a spontaneous pregnancy and doing testing in the pregnancy, or not doing testing at all, is a possibility. Doing that IVF process with PGT is an option, but also you can do donor gametes. So if the male partner is the one with PKD and you don't want to go through the process of the PGT process, you could have donor sperm, for example, and use that to become pregnant. And then we would know that PKD condition would not be passed on. Also, some couples decide that, all of this seems like too much. The risks to the pregnant person may be too much to become pregnant if they have a poor kidney function, and adoption may be something that they think about. or some couples choose not to have children because of, you know, all of their health risks or other decisions that they make. And so all of these are important things to think about and talk about prior to becoming pregnant. And then the last thing I'll say is that, you know, this patient decision making, we've all sort of emphasized this in our talks, where it is important to have conversations with providers that you trust about how hard these decisions can be. It is very normal for people to feel like their body has failed them, that, you know, some people say the one thing their body was meant to do was to have children. I know everyone doesn't feel that way, but some women do feel that way. And they may feel guilty or have, you know, feel like grieve over the idea that they might not be able to have children of their own or carry them on their own or carry a pregnancy. And then some people have, you know, this idea that maybe they're gambling with their health. I mean, I think some of the questions we've seen in the Q&A about, well, you know, risks and benefits, is it safe, is it not safe? That's like a constant question that people have when they have a health issue that could be exacerbated by pregnancy. And obviously, this is about complex decisions that need to be made. You have to think of your own health as the pregnant person and your own survival and long-term health of the kidneys. You obviously are thinking about the outcomes for your children. You know, what if they inherit this genetic disease? Could there be a fetal effect, as Dr. Gulati mentioned? We see that sometimes with ADPKD. And then what about the partners and family members? You know, this is not just an individual choice about how to build your family all of the time. And there may be differing opinions from partner to partner about what to do. And then in medicine, I think we try our best to not be very paternalistic about our advice, but we are sometimes. And, you know, trying to balance the medical risks and patient autonomy as a constant, you know, navigation, a constant dance. And when we talk about shared decision making, this is what we're talking about, like balancing all of that information and coming to the best choice for you. And as the KDIGO guidelines say, and all of us have said, each person's care should be individualized. And so we want to recognize that. So that is all that I have. I have my contact information here, and I just love to share these pictures of my kids. These are my 2 IVF conceived babies. My husband has PKD, so I'm very invested in this work, not just professionally, but personally, and happy to answer any questions that you all have now or in the future. Thank you so much.
Thank you so much to our presenters for sharing this important information. To help us stay informed and more confident in managing our care and the care of our children. Dr. Reed, we have an attendee's question asking if there is a family history of PKD, do you recommend genetic testing?
I would say that this is a personal choice. So you don't need the genetic testing to make the diagnosis of PKD, obviously in a symptomatic person. We definitely have patients that decide not to do the testing because they don't find it's important. If somebody's going to end up needing like a kidney transplant or something like that, you know, obviously there could be symptoms or obvious signs on ultrasound from a donor. But if it's, you know, more of an extended family member or something, then it may be worth knowing the genetic cause. I think really the reason that I tend to see people is because they're considering in vitro fertilization. And so they want to know what the genetic cause is so that they can proceed with that. Also, there can be some prognostic information with the genetic results. So it can kind of give you a little bit more information about how the PKD could progress or age of, you know, end-stage renal disease, for example, depending on the gene that's affected or the mutation. So it's really an individualized choice. And then I would say that it's getting better now, but in the past, genetic testing wasn't always covered by insurance if it was for PKD. It is better now. There's labs that have much more favorable insurance policies. And so it does tend to be more affordable now. And I would say for couples that are considering IVF, they have probably already thought about cost, and the cost of a genetic test is a small cost compared to the cost of the rest of the process. So they may be more willing to pay out of pocket for testing if that's what's required.
Okay, great. Thank you so much for that answer. I'll move on to another question from an attendee, and I'll direct this to Dr. Chapman. Our attendee asks, does hormone replacement therapy affect cyst growth with PKD? I've read the answer to a question posted previously. However, the answer speaks of PLD only. If so, are there other natural recommendations to help with symptoms that are safe?
So the answer about estrogen on kidney cyst growth is not fully understood. We do know that women have milder disease than men in general. So that would speak to estrogen really not impacting cyst growth in the kidney per se. Now, that's a little different than the impact of pregnancy hormones. And we just haven't had a chance to look at women's kidneys pre and post pregnancy in a systematic way to know if there's an impact on kidney growth from pregnancy. That said, even if we did see it, we wouldn't know for sure if this was estrogen or progesterone. So unfortunately, we just don't know. We certainly have seen the association in liver cystic disease.
Okay, thank you, Dr. Chapman. The next question I'll direct to Dr. Gulati. Our attendee asks, can any child with the genetics for ADPKD develop early onset and very early onset ADPKD?
Yeah, I think that's a very good question. I think we need to separate out the very early onset and the early onset. The very early onset ADPKD is usually a more complex genetic setup than early onset ADPKD. Very early onset means you have a severe onset before 18 months of age, and usually those kids tend to have either a rare combination of having two defective PKD alleles, while you only need one defective PKD allele to manifest the disease in the usual dominant disease of ADPKD. Or it could be a rare instance of like where there is another ADPKD gene, another PKD gene contributing. And then when you come to early onset ADPKD, which is before 15 years of age, and you have a more severe manifestation than the other members of the family who have ADPKD, but the same genetic mutation, it could still be the same PKD1 or PKD2, usually PKD1 gene defect, but in that particular child there is another genetic makeup which is not recognized, and there is another environmental influence which is again not recognized, and this is something that we call intrafamilial phenotypic variability within families, where different members of the family have the same gene change but different disease presentations in terms of severity. So that's a known fact in ADPKD which has not been fully understood as yet. But I think in the very early onset cases, there definitely is a chance of having a more complex genetic makeup.
Okay, thank you, Dr. Gulati. And I'm going to actually continue with you and pose another question from one of our attendees. What are the symptoms of ADPKD in young children?
So symptoms of ADPKD in young children, the most, the more well-defined symptoms would be, as we said, like, the majority of would be asymptomatic, but then symptoms could be in terms of high blood pressure. There could be some protein leak in the urine, and that's something that's seen less commonly. Then we see kidney stones in sometimes kids with ADPKD. That could be another symptom. For some reason, it's not very well defined that, bedwetting or just prolongation of bedwetting is not directly related to ADPKD, but we do tend to see, children with who are at risk for ADPKD, and they'll come to clinical attention just because of prolonged bedwetting past a certain age, and then we tend to screen them. So that's one other thing that comes to clinical attention. And then high blood pressure, we said. Very rarely, so pain because of ADPKD is not a common thing that we see in kids, but very rarely we will have, instances where the kid will have like one very big dominant cyst, and that big cyst can be the cause of pain or even cyst infection or cyst hemorrhage. And in some circumstances, like that big cyst needs to be removed. It's again a less common occurrence, but tends to happen sometimes. So those are usually the symptoms that we see in pediatrics.
Thank you, Dr. Gulati. And let's switch gears here. This question will be for Dr. Reed. Dr. Reed, our attendee asks, IUD versus progesterone oral contraceptive pill, which would be more appropriate for a patient with PKD?
So if you're thinking of using it for, it depends on what you're trying to use it for. I would say the progesterone only pill has some downsides in that it's a little bit finicky. You kind of need to take it at the exact same time every day, or it increases your risk of pregnancy. The IUD, the hormonal IUD is nice because if you also have bleeding issues, like heavy bleeding, for example, it can treat that. It also is easy, like it goes in, I mean, easy once it's in. It goes in the office and then, it's there and it's working. And so there's nothing that you have to do to make it work or not work. And as I tell my patients, there's nothing you can do to mess it up. It's there and it's working, and it can also stay in for quite a long time. So it kind of just depends on what your goals are. I think in general, as OBGYNs, we recommend long-acting reversible contraception like an IUD or the Nexplanon, which is the one that goes in the arm, over pills, just because it's easy for people to forget to take pills or not take them exactly the same time. And so then it increases their pregnancy risk.
Okay, great. Thank you. And one more question, Dr. Reed. Does having ADPKD put you at risk for hormonal issues like painful periods, PMDD, etc.?
Not to my knowledge. I have not seen that in my patients. I don't know, Dr. Gulati, if you know, you're seeing menstruating girls sometimes with PKD. I haven't heard that, but I don't have like a specialty clinic in GYN for PKD.
Yes, so usually in adolescents, adolescent girls with ADPKD, there isn't any data saying that there is a higher incidence of any, pain or periods, problems or. So we do see, some adolescents with periods problems, but usually, what is known in the field is that the polycystic ovarian syndrome is not typically an association of polycystic kidneys. And usually those are two separate conditions. And, so it isn't, there isn't data to actually show a direct link between those symptoms or conditions.
And I think that concludes the questions that we had today. And this concludes today's program. Thank you all, and I hope you have a great evening.